Hi, I'm Jan Shoenberger from Los Angeles County General Medical Center. This is Neurology and Psychiatry. We're going to kick it off with some basic neurology, including assessment of neurofunction. Now, these are reflexes. We test them all the time when we're looking for different etiologies of disease, and they're the kind of things that sometimes I forget before I take tests, and I have to remind myself the night before a test which nerve root goes with what. So when we're talking about muscle reflexes, for example, we're testing a biceps reflex, that goes with C5 and C6. Triceps is C7. The knee, importantly, is L4. That's a really important one to remember for the purposes of clinical medicine and for tests, of course. And then ankle is S1. Now, in terms of cutaneous reflexes, there's some other ones that we need to know here. This is particularly important if we're, for example, dealing with a patient who might have something like Guillain-Barré and have a sensory level, or a gunshot wound in a sensory level. Where do these sensory levels lie? If you're talking about upper umbilicus area, that's T8 to T10. Below the umbilicus, we get a little bit lower in the thoracic region, T10 to T12. And then the cremasteric is your L1 and L2, and your anal is S2 to S5. These are important kind of thinking about cauda equina, for example. These are your dermatomes. This is, again, kind of mostly reference slides. You don't need to memorize all these things, but it's important to remember sort of where the dermatomes start and where they kind of go down to in terms of when you're testing different levels, again, where your touching goes with different spinal levels. And so those are here for your reference as well. In terms of which dermatomes are most testable, most likely to be asked about, remember that when you're talking, it's good to kind of know where the stop points are along the body as you go downward. So if you're at clavicle, you're talking about C4, C6, C7 is middle finger. I'm not going to show that to you, but C6, C7, C8 is little finger. So the lower C-spine goes along the fingers here. Nipple line is T4. Umbilicus is T10. We just talked about how upper and lower is like T8 to T10, T10 to T12. So umbilicus is T10. Linguinal ligament would be about L1. The knee is L4, same as with your knee reflex as well. And so kind of running through, and we've given you a few little mnemonics here to remember those if you have a hard time. So C4, C6, C7, C8, T4, T10, L1, L4, going on down. All right, cranial nerves, a little review here. We're not going to go through testing all the cranial nerves. It's kind of something we assume that you know from medical school, but what are some of the testable little things to know about cranial nerves and their little idiosyncrasies? So cranial nerve 3 palsy. Now, we talked about cranial nerve 3 in the ophthalmology section. If you haven't watched that one, it's a good one. Go back and take a look. But cranial nerve 3, if you remember, runs along and innervates our pupil, and the parasympathetic fibers that innervate our pupil run along the outside of cranial nerve 3. And so those parasympathetic fibers help us basically make our pupil smaller. Remember that sympathetic fibers is the fight or flight, make our pupils big, let in the light so we can run from the lion. Parasympathetic makes your pupil smaller. And so those fibers run along the outside of cranial nerve 3 to our pupil, innervating the pupil for its dilation and shrinkage capacity. So we can get cranial nerve 3 palsies, but there's a couple different types of ways that can happen. One is a pupil sparing cranial nerve 3 palsy. So that means that it's basically the cranial nerve 3 that's running from the inside, not the outside. And so that can happen with infarction and with things like diabetics. When we talk about a diabetic pupil-sparing cranial nerve 3 palsy, what you're talking about here as you look at this eye, so you see that this eye is deviated out laterally. Why is that? That's because if you've affected your cranial nerve 3, which does a lot of extraocular eye movement, but one of the ones it doesn't do is the lateral rectus movement, which is cranial nerve 6. Remember, LR6, cranial nerve 6. So if your cranial nerve 3 is out and you have unopposed cranial nerve 6, it'll pull your eye out laterally. So that is an eye, the one that's looking out laterally, where cranial nerve 6 is intact, but cranial nerve 3 isn't counteracting it because it's infarcted from diabetes or hypertension, etc. That is pupil sparing. The pupils look normal here. And that's because when you affect your pupil, when you're talking about a cranial nerve 3 palsy, you're talking about the outside of cranial nerve 3 where those parasympathetic fibers run. So if I affect that from the outside through compression, for example, and that causes my pupil to dilate because I have unopposed sympathetics. If I've taken out the parasympathetic fibers that run along cranial nerve 3, I take those out by pushing on them with an aneurysm, something like that, and then I get unopposed sympathetic input, which causes my pupil to dilate. So on the side where you see the dilated pupil, that is someone who might have, for example, an aneurysm, or at least we're ruling that out and seeing this and isochoria or unequal pupils. Now, the Glasgow Coma Scale, another one of these basic neuro assessments, right? Just to remind you here what the components are, you have the eye opening, you have the verbal, and you have the motor response, and they're graded in different ways. These are always good to remind yourself before a test, because certainly they can present you with a clinical vignette describing a patient who has different elements on the GCS and ask you approximately what their GCS is. So if this is something that's hard for you to remember, just review it the night before your test to make sure that you have it on board. I often remember, I know that there's one that has 4 and one has 5 and one has 6 elements, and I have a hard time remembering which one is which, but I think about it this way. I think about the eye, which is the highest, that's 4, the verbal, which is the next one, which is the mouth, that's 5, and then motor, which is 6. So 4, 5, 6. 4 elements, 5 elements, 6 elements. That helps me remember. At least I can start to break it down as to what those elements are within the different parts of it, but that may help you remember which one has 4 elements, 5 elements, 6 elements. Altered mental status, certainly something that we need to know the differential by heart. And here's just some reminders. Remember that a patient that is presented to you with altered mental status, we start with the ABCs, of course. We want to always check a glucose because that's a quick thing that we can fix. We also want to consider things and antidotes to altered mental status with things like thiamine or naloxone. But in the old days when we talked about coma cocktail, which was like, empirically give the person who's in a coma these different things to see if you can reverse what's going on, remember that flubazenil, which is a benzodiazepine overdose antidote, is something that we used to throw into the coma cocktail, but you really don't want to just give that willy-nilly because it can also precipitate seizures. So that's why it says here, use flumazenil with care, not something that you want to be just giving someone who's altered. The AEIOU TIPS mnemonic is a really good one to help remind you of the basic differential for patients who present with altered mental status. Everything from alcohol, which is so common in our society, epilepsy, insulin, right? Could it be hypoglycemia, opioids, uremia, trauma or temperature, hyperthermia, infection, different poisonings, psych, and then S gives you stroke and shock. It's a pretty broad differential, but so is the differential for altered mental status. So if you're ever at a loss kind of figuring out what's going on, don't forget to run through your AEIOU TIPS as a really good mnemonic to give you those big categories that could lead to altered mental status. Now let's get a little bit into the weeds here and talk about some of the brainstem reflexes that you're supposed to know about that you don't test every day, but certainly could be on an exam should you be facing one, because you're supposed to know about these. We just don't check them very often. So brainstem reflexes. Remember the doll's eye reflex, the oculocephalic reflex? This is something if we are faced with a patient who's comatose, we're often checking this because it is a brainstem reflex that should be intact if their brainstem is intact. So this is something that would be absent if they're actually awake and have good neurofunction. You don't want to do this in someone who might have any kind of C-spine trauma because we're going to be turning their head from side to side. So what does this look like? If their brainstem is intact and I move someone's head to the side, their eyes should move in the opposite direction if their brainstem's okay. So if I move your head to the right, your eyes should go this way in terms of, that's why they call it doll's eyes, if your brainstem's okay. So if your brainstem's okay, you should be like a doll, where if you turn your head, the eyes actually go that way, that they move. But if the brainstem is injured and you've lost this reflex, then what happens is when I turn your head, the eyes just go with you. They just go with you because they don't have that reflex to look the other way. The reflex is you turn my head this way, my eyes want to go look over here, and that means my brainstem's functioning. But if my eyes just go like this, brainstem no good. So that's the doll's eye reflex. There's also cold calorics that you can do. This is the oculovestibular reflex that we're testing here. Again, this applies to comatose patients. We're trying to test this particular reflex. Basically, the patient needs to be supine, but their head elevated 30 degrees. You basically want to look in their ear first, and then you're going to irrigate the ear with ice cold water, and this will cause this reflex to kick in. So if the brainstem and the cortex, it tests both things, are intact, you will see nystagmus happen in relation to this cold water being irrigated into the ear. And so it's the cow's mnemonic, cold, opposite, warm, same. So it means that if the brainstem and cortex are intact, you will get nystagmus with the fast component directed to the opposite side. So if I put cold water in this ear, my brainstem and my cortex are okay, then I get fast nystagmus going the other way. But if it's injured, but the brainstem's okay, then the eyes will just deviate that way. This one's a really bit of a complicated one. Again, it's one of those ones, review it before a test. You don't do it in your clinical practice very often. So remember this cow's mnemonic, review what it means. Here it is for you. If the brainstem is injured, you won't get any eye deviation at all. Again, that goes back a little bit to the doll's eyes where it just sort of sits there. So that's what you'd see in that particular reflex. So something that's a little bit niche, but something worth reviewing. All right, corneal reflex. This is something you test in awake patients. It's testing your cranial 5 and your cranial 7, which basically means that if you touch the cornea, you should blink. That's like a normal reflex. That's your corneal reflex. If you have some kind of like decreased blink in the other eye that it doesn't just do that reflex that's so common, that's protecting your eyes and your vision, if you have a decreased blink, that could mean that you have some kind of a brainstem or a cortical injury. And then there's lateral gaze. This is something that we can test again in awake patients because we have the medial longitudinal fasciculus, which is basically the sort of neuronal tract that connects your oculomotor nuclei and runs through your brainstem. And so basically what happens here is if you have what they call an intranuclear ophthalmoplegia, which basically means that your cranial nerve 3 and 6 aren't talking well to each other, that this MLF, this basically neuronal tract that's highly myelinated that connects these things, if it's affected, then you're going to basically have a problem looking laterally. The eye on the affected side can't look at the nose. It has a problem with lateral gaze because you have this highly myelinated tract that's affected. That can happen in things like multiple sclerosis and different diseases that cause demyelination. You may see a problem with eye movement. If you examine their extraocular movements, you may see a problem with lateral gaze. That could be an INO, indicating a problem with this myelinated tract that connects the different systems that take the input and move your eyes to the lateral sides, and that's really what an INO is. So here's a picture of what that might look like. So for example, patient at baseline, I'm looking straight ahead, I'm testing your extraocular movements, I have you look one side, your eyes move laterally quite nicely, and then I have you look the other way, and one eye goes, and it has a little bit of nystagmus, and one eye gets stuck there. And that may be a right INO, or internuclear ophthalmoplegia, indicating, what does that indicate? That there's a problem with this myelinated tract that connects the systems that make your eyes move laterally together, that you have this conjugate lateral gaze. If you can't do that well, it may mean that you have multiple sclerosis or one of these demyelinating diseases, of which there are many, disconnecting the systems that lead to nice, smooth lateral gaze. This is one of the reasons with patients with neurologic complaints we want to do good extraocular movement assessments, because if you see a problem with the lateral gaze, which you will pick up on if you do that exam well, you know that there's something wrong back there in the connection system, which is a highly myelinated system. All right, let's talk about headache, which is a very common clinical complaint, and some of the things that are on the differential and some of the little tidbits we need to know about them. So one of the complaints here, one of the conditions that we want to think about is trigeminal neuralgia, or tic douloureux is the sort of little term for it as well, which is basically someone who comes in with lancinating, electric, unilateral facial pain. This is cranial nerve 5, our trigeminal nerve, and they're coming with this just terrible, terrible pain. These patients are so miserable. It's not really a headache. It's more of facial pain in terms of how they present, but there's a component of headache there as well. This can be compression of the trigeminal nerve is one of the reasons that this could happen. It's not pathognomonic. It can also happen idiosyncratically as well, but we want to think about things like multiple sclerosis in patients who present with this type of peripheral nerve problem. It often happens in middle-aged women more than men. Again, it's these electric, brief, intermittent, severe attacks of pain one side of their face, and in between episodes they're fine, but the pain is so intense. Their neuro exam should otherwise be normal because this is a peripheral nerve problem. How do we treat patients who have this horrible trigeminal neuralgia? Well, we have to rule out other things. We want to look for dental disease and other problems, TMJ, think about all the things that can cause peripheral nerve problems, but if this is truly what it is, then the drug of choice is carbamazepine, and this is very testable because it's this very unique connection between trigeminal neuralgia and this anti-seizure drug, carbamazepine. So know that this is one of the indicated treatments. There can also be a surgical decompression if there's some kind of mass or something pushing on the nerve causing this lancinating pain. All right, you could give a whole lecture on migraine, talk about all the features of migraine, but for the purposes of exams, what are kind of the bullet points when it comes to migraine? We know that it has a predilection for females, and mostly at younger ages. Often there's a family history. This is not exclusively true, but this is kind of generalizations that sometimes can be testable. This is often a unilateral headache that feels very pulsatile. It can be severe and throbbing, and it can last anywhere from a few hours to a few days. Sometimes people have been suffering with migraines for several days. Not only do they have a headache, but often what comes with it, nausea, vomiting, and photophobia, and even phonophobia. Sounds can also be irritating. So often it's the patient who wants the lights off, coming in with the sunglasses, that kind of thing. These can happen with or without an aura. The classic migraine is with an aura. This may be scotomata, where they see sort of flashing lights, or even focal neurodeficits. You can see migraines, hemiplegic migraines. So they can come with all kinds of temporary neurologic deficits that go with their migraine. Depends on which part of their brain is actually involved. There's a lot of different treatments for migraines. Some of these are preventative treatments. Then there's also the treatments for when they're actually having the pain. So a lot of people with chronic migraines might be on some drugs to try to prevent it. Things like tricyclic antidepressants, beta blockers, calcium channel blockers. Some of these are aimed at trying to reduce the vascular nature of these things. And there's some newer drugs out there that you see advertised that are expensive that may also be newer preventative measures for these particular migraines. So abortive therapy, once the migraine's in place, what do we do for it? Probably number one therapy is the dopamine antagonist. We're talking about metoclopramide, chlorpromazine, prochlorperazine, promethazine, all of these antiemetic drugs that fall into the dopamine antagonist category. This is kind of number one up in terms of good effect. Now remember that they have a side effect of akathisia, the get up and goes. That's one thing to also remember. Probably next in our migraine cocktail would be ketorolac and acetaminophen, also still very effective for migraine. And then you also have patients who respond well to ergotamines. These are also a unique drug for abortive therapy for migraines, but they do have some important contraindications. People who have coronary artery disease, vascular disease, bad uncontrolled hypertension, people with who are pregnant, for example, we don't tend to give the ergots in those patients. But for some patients, these work pretty well. And they may even have them at home to try to abort their migraine. And then sumatriptan. This is contraindicated also. This is a serotonin-based drug, heart disease, hypertension, and so there's specific indications for this drug, but some people this works quite well for them. In terms of rescue analgesics, opioids are on the list here, but they're way down the list. Certainly opioids are not a preferred therapy for migraine, so should really be a rescue drug if you really are faced with very little options. You want to try all the other things first, and opioids can cause a rebound headache. So there's really a downside to them as well. Cluster headache, another particular type of headache that we need to know a little bit about. This is often middle-aged males, more common than females. It's a unilateral headache. It lasts in the 30 to 90-minute range. They often have sort of, the reason they're called clusters is because over several weeks, they kind of have a bunch of them in a row. They can be circadian and they can come at certain times of the year. It's sort of an interesting phenomenon. They don't have much of a prodrome, unlike migraine with aura, for example. They don't necessarily feel it coming on. And not only do they have headache on this one side, but they can have an injected eye and a runny sort of eye on that side and a runny nose. So increased lacrimation and rhinorrhea on that side would be classic for a cluster headache. So they could give you a vignette of a middle-aged male that's coming in with this new unilateral headache, and they may throw in his eyes a little bit red, not so red that you think about acute angle closure glaucoma, although checking an intraocular pressure would be a good idea. But maybe they have some lacrimation and rhinorrhea. They can even have meiosis and a little bit of ptosis on that side as well. And it can be precipitated by alcohol, nitroglycerin, even histamine, they say, might cause the attack. But what's interesting about cluster headache is the treatment. The treatment for cluster headache is oxygen, which is a very unique treatment for a type of headache, for this type of headache. So again, very, very, very testable. Put oxygen on them and that may help. You can also do things like intranasal lidocaine may also have an effect, and then you have your abortive therapies here as well. Tension headache, important to differentiate from the other types of headache, which is kind of the rubber band around the head, worse at the end of the day. It's kind of constant. My temples, feel sort of tight, can be minutes to days. They don't typically have the other features, especially on a test, of migraine or cluster headache. So they wouldn't have the photophobia or the nausea, the vomiting, or any kind of focal deficit. That doesn't go with tension headache at all. And so that's important to know those characteristics. It's sort of late afternoon, my head is being squeezed, I don't have really any other signs or symptoms. That's tension headache. And then there's other types of headaches that we have to think about, which are the toxic metabolic headaches. These usually are global because it's a bilateral process. It's vasodilation of pain-sensitive arteries. Fever can cause, this is where the headache from fever kind of comes from. But there's also other metabolic causes, things like alcohol, foods with tyramine, hypoxia, carbon monoxide. That is one of the red flag headaches that we have to always think about is carbon monoxide as a cause. And that headache is usually more global, can also look like flu, and other people in the house are sick. But don't forget about carbon monoxide because there's certain therapies there like hyperbarics, oxygen that we want to think about with bad carbon monoxide poisonings. Some other types of headache. These are all the differential of the emergency types of headaches that you can't miss. This is also on the list. Idiopathic intracranial hypertension, which we used to call pseudotumor cerebri because it basically is acting like increased intracranial pressure as if they had a tumor, but they don't have a tumor. They have intracranial hypertension. This is related to problems with the venous side of the circulation in the brain. So it is usually young, obese females, the classic case of IIH. They often have PCOS or irregular menstrual cycles, amenorrhea. They come in, they've been having headaches. They've been having nausea with these headaches. It sounds a lot like migraine. But on top of that, they may be describing to you some visual changes. And the real serious part of IIH is vision loss, ultimately. That's the emergency about IIH besides the headache that they're having. So basically, they have impaired CSF absorption leading to too much CSF sitting around, causing increased pressures. There's no mass, there's no necessarily obstruction, but it's a venous outflow problem. That could be related to cerebral venous thrombosis. It could also be related to problems with their venous sinus tracts draining. That could be another problem leading to backup of CSF, causing this intracranial hypertension, increased intracranial pressure. So we mentioned the blindness. They could even have palsies, things like this cranial nerve 6 palsy, so important to test extraocular movements. And so you want to look for that papilledema. That is the classic finding in intracranial hypertension because of the increased ICP. So you want to look with your fundoscope and look back at the papilledema. And if you talk to a neurologist about this, they may want you to get an opto consult to basically classify and quantify how much papilledema we're talking about. What will the CT scan look like in patients with IIH? Well, it could look normal, but they also may have slit-like ventricles as well as a result of this pressure. But you won't see things like mass effect from a tumor. That's not what's going on here. When you do the LP, that CSF is going to squirt out at you because of the high pressure. So you will see pressures higher than 25 and it will be very detectable when you do your LP. Really important to measure that opening pressure. The treatment for IIH is either repeated LPs to basically take off that fluid and decrease the pressure. They may also be treated with acetazolamide, which is a carbonic anhydrase inhibitor, a diuretic, may also be helpful here. Weight loss can be also helpful, and they may even need a CSF shunt if it's very severe. And they may need fenestrations in terms of the pressure along the optic nerve if they're having visual complaints. So it's again, the real threat here is the vision loss, and so we want to do the LP and check the opening pressure. Other types of headaches that are in our differential, did someone have head trauma? Is this a post-concussive headache? And you know that post-concussive headaches can last hours to days after they've had some kind of head trauma. It can also be accompanied with things like vertigo and vomiting and concentration problems. But if you do a physical exam on these patients, a neuro exam, it's going to be normal. And their CT scan will be normal, which is what leads you to the diagnosis of concussion. Prognosis is generally excellent here, very common in kids who are running around bonking their heads, but there can be neuropsychiatric sequelae, so good to refer them for further care in that regard. Post-LP or spinal headache is another thing on the differential. Did they recently have an LP? That could be the cause of their headache. Much, much worse with upright posture. That's one of the classic signs of a post-LP headache, differentiating it from other types, which is that as soon I was lying down, I was okay, and as soon as I sat up, boy, did the headache kick in. We know that this correlates with the needle that's used in LPs and how much fluid is removed, for example. So those things can correlate with the incidence of this type of headache. The treatment for this, ultimately, the definitive treatment is blood patch, but you can also try some other abortive therapy like caffeine. That's kind of unique for this particular type of headache, or other regular kind of migraine cocktail type therapies as well as hydration may help as well. But ultimately, often, if those things aren't working, traditional headache therapies, go for the blood patch. That can be the definitive thing to sort of stop the leak. All right. Subarachnoid hemorrhage, one of the diagnoses that we truly exist for. We've got to pick up that needle in the haystack that has a definitive treatment when we have a sentinel bleed, for example, and we want to prevent that big bleed from coming later. So subarachnoid hemorrhage is on our differential for patients who come in with a sudden onset thunderclap headache. It's often secondary to an aneurysm, although it could be something like an AVM. Happens all across age groups, and again, they may have a sentinel headache, which basically is the aneurysm leaking, causing a not so serious headache before the thing blows and causes a devastating intracerebral hemorrhage. So this headache is typically described as sudden onset and, importantly, maximum onset, and often different from previous headaches. Now, we say here that it can often be described as the worst headache of their life, but honestly, that's not really a factor that will help you differentiate this headache from other types of headaches, because often patients aren't in the emergency department for a headache that isn't the worst headache of their life. So really the characteristics that you want to ask about is maximal at onset versus gradual onset. When you hear gradual onset, to me, that kind of speaks against subarachnoid hemorrhage. It's that thunderclap. It hit me hard right at the beginning and then got better after that. And a little bit different maybe in quality. It can also be accompanied by nausea and vomiting, meningismus and neck pain, also important things to ask about because those are often part of it as well. There is the Ottawa subarachnoid hemorrhage rule, which we've reproduced for you here. This has come out in several publications. There's an ACEP policy that we've linked here that was published in 2019 that officially endorses the use of this rule. This basically helps you rule out subarachnoid hemorrhage. So you basically go through these different symptoms. Do they meet any of these? If they meet any of these, then you have to proceed with the workup. So it's symptoms of neck pain. Are they over age 40? Did they have any witness loss of consciousness? Did the headache start during exertion? The thunderclap quality that we've talked about, and then limited neck flexion or that meningismus. If they have any of those, you've got to work them up. If the answer is no to all of them, you can safely exclude subarachnoid hemorrhage. So that Ottawa subarachnoid rule was there to basically help us stop the workup in some patients. So that's important. You can go through that rule, and it now is ACEP endorsed, so important to know. All right, so there's a lot of people that this would apply to. This rule should help you reduce the imaging and other testing. It shouldn't make you increase it, so it shouldn't force your hand to do the testing, but it'll help you rule out some people. You know that we have studies now to show that with modern day CT scanners, if you get that CT scan within 6 hours, the CT theoretically is 100% sensitive to find blood in the brain in terms of detecting subarachnoid hemorrhage. That number goes down after 6 hours, so it's not good enough by itself after 6 hours. But if you can get that CT within 6 hours of their headache, and you've got a modern generation scanner, which most places do now, your CT essentially rules out subarachnoid hemorrhage. So CT will often show this to you, but if the story is good, you have to proceed further. You'll see on this slide it says always do the LP, and you could argue with me and say that there's some people out there that are doing CT angiograms as their workup, looking for the aneurysm in that particular way, beyond the scope of this lecture to have the LP versus CT angio debate. But remember that you just need to do something more. Whether it's an LP or a CT angio, we can debate that, but go further. And the classic answer is to do the LP for the purposes of a test, for example. What we're looking for with that lumbar puncture is we're looking for how many RBCs are there. So we take tube 1 and tube 4 and we collect it, we send it to the lab for cell count, looking at red blood cells. Because if we have a traumatic tap, for example, it means usually that you'll get RBCs in tube 1, but by tube 4 they should have cleared. That's why we say tube 1 versus tube 4 to differentiate traumatic tap versus true subarachnoid hemorrhage. But we're also looking for xanthochromia, which is basically if red blood cells have been hanging around in our CSF for hours, as they break down, they cause xanthochromia. So it takes 6 to 12 hours to develop, but that may be one of these late presenting subarachnoid hemorrhages. That may be your sign that there was a sentinel leak. There were red blood cells in there. They're now degrading, and that's what you see as the xanthochromia down the line. So CT angio has a very high sensitivity for aneurysms, but the problem with it is that it generates some false positives. So you may have a patient that comes in with a headache. You're working them up for subarachnoid. You do a CT angio. Maybe it shows you an aneurysm. Doesn't necessarily mean that that aneurysm caused that headache. We know that there are people walking around, 1 to 2% of the population, that have incidental aneurysms that have nothing to do with the headaches that they're having. So that's the downside to the CT angio, which is if you find an aneurysm, you still have to do the LP to determine if it has bled or not. And so it's not a perfect test for that reason. We can have that debate, as I said, beyond the scope of this particular lecture. But if we do find a subarachnoid hemorrhage, what do we want to do for that patient? Well, we want to do aggressive blood pressure control, keeping that systolic under 160 with something like nimodipine, which is only available PO, which is why it says PO or nasogastric tube if they're not awake enough to take the pill. And that will help prevent some vasospasm. And then we want to consult our neurosurgeon if we truly find that devastating subarachnoid. Here's a picture of what subarachnoid looks like. This is a bad one. You see it's filling that white, it's filling all the little spaces, and you see that sort of circle of Willis there, the Death Star as they call it. This is just a very bad finding and very difficult to recover from. So what we're trying to prevent when we're looking for sentinel leaks is this happening, because a certain percentage of those patients with sentinel leaks will end up coming in like this, where they'll be comatose and it's game over. Not much we can do about it. So that is a devastating subarachnoid hemorrhage.